I first really want to thank Dr. Bonnie Hennig-Trestman, who is certainly my wife and colleague, and someone who has really helped to drive so much of the work in Huntington's as it relates to supporting our patients and their families. So let me first start off with a focus on, what are the issues and the risks of suicidality and suicidal thinking in patients with Huntington's disease. People have studied this issue for years, and going back now 20 years, some of the early studies focused on suicide risk in Huntington's, focused on, at the time of genetic testing and the provision of pre-symptomatic test results. So that was some of the earliest work that suggested there might be a risk at that time. A few years later, there were studies that suggested there were other critical periods of suicide risk. In a study from the Huntington Study Group database with over 4,000 individuals, the findings suggested two critical periods for increased risk of suicide in individuals with Huntington's disease. The first was immediately before receiving a formal diagnosis of Huntington's, where they were just expressing enough symptoms that they were formally diagnosed. And the other period was in stage 2 of Huntington's disease, a period when independence of function begins to diminish. Studies that occurred later on, just about a decade ago, had to do more broadly in, again, about 2,000 people in the Huntington Study Group, but focused on a range of different challenges. Overall, the study suggested that about 19% of people with Huntington's disease reported suicidal thinking. They also found that it was particularly relevant in people who also had depression or anxiety and were irritable or were expressing bouts of anger and aggression. Those were significant predictors of individuals who might be at risk for suicide. In a subsample of those with the greatest suicidal thoughts, alcohol use and drug use were also predictive. More recently, a study was done that again confirmed a similar increased risk overall of suicidal thoughts and behavior in people with Huntington's disease. And it suggested that the potential risk is elevated throughout the course of the illness, and that untreated psychiatric comorbidities are common risk factors, with depression being the most prominent. So all of this suggests that it's really important for us to focus on the co-occurring problems of mental illness in the context of Huntington's disease. As many as 90% of people at some point in the disorder will experience problems with sleep. Many, over 2/3, will have problems with apathy. About a half of individuals with Huntington's disease may experience problems with mood changes, agitation, disinhibition, or impulse control problems, depression or anxiety. Having hallucinations or paranoia, super suspiciousness occurs pretty rarely, probably in less than 5% of people. And we'll go into each of these areas in more detail during the course of this conversation. So first, when we're talking about mental illness, as we've been beginning to discuss, the first issue is assessing it. What's there? Are there other medical or psychiatric issues? Could there be problems from the medications people are currently taking for a general medical condition or for other reasons? As well, things that can occur in the environment, changes in the daily schedule, can be difficult for many individuals with Huntington's disease. So in the assessment, it's important to obtain information both from the patient as well as from the caregivers and the family. And it can be a challenge, since all too often people with Huntington's disease may not understand or see their own problems, and they may minimize their own behavior. And on the flip side, many family members don't want to upset their loved one. So in general, the first choice is to work with patients and families to reduce the behavioral problems, really focusing on what are those symptoms. But many times we just can't change the person's behavior. An important thing to recognize is even when we can't change that individual's behavior, we are able to react differently to it as caregivers and as family members. That we can change, that we can control. If indeed during the assessment it becomes clear that medication is required, we need to think about the symptoms specifically as well as the stage of the disease. And medication needs to be reassessed over time. It may have been initially very effective early on in the illness, but it may change as the disease progresses. And the side effects may get worse, may change, or may disappear completely. So we need to be aware that the brain and the illness are moving targets, and that even if we find some medications that work today, that doesn't mean in a year or two they will keep working as well. I mentioned that so many people with Huntington's disease have problems sleeping. This can either be problems falling asleep or in staying asleep. Some of the reasons that can cause this can certainly be other medical conditions or other psychiatric conditions, but pain is something very important to recognize. If someone is uncomfortable, it's going to be very difficult for them to fall asleep. Sleep disturbances can occur as a side effect to the medications people may be taking. Certainly, alcohol or recreational drug use can make it difficult to fall asleep or to stay asleep. Caffeine drinks, whether it is coffee or tea or different sodas, have a lot of caffeine, and caffeine will keep you up. And so it's important to try to look at all of these different issues to try to, at the very beginning, eliminate the source of the problem so that people can sleep better. The other thing is that many people have poor sleep hygiene. And I'm sure many of us have been guilty of occasionally staying up late watching movies or videos, surfing the web. It's important not to do that. And when it's time to go to bed, to actually turn off all of these devices, go into a dark room, and allow yourself to fall asleep. Another problem is many people take long naps during the day and then complain that they can't sleep at night. So these are all elements that can contribute to sleep problems. So, in terms of basic recommendations, certainly if someone is addicted to medications, to substances that are recreational, whether it's caffeine or alcohol or other drugs, other stimulants, treating the addiction for what it is can make a big difference, and focusing on better sleep hygiene. If it becomes appropriate to use medication, there are a range of medications that might be beneficial. For some, melatonin may be beneficial, but keep in mind that many of the melatonin products that are bought in a pharmacy over the counter are unregulated, and the milligram dosing may be completely different from what really is there. So an appropriate prescription for melatonin may yield better results. There are lots of sedating medications that can be prescribed. If indeed the problem with sleep is a depression, because insomnia can be a part of depression, then taking an antidepressant can really help by treating all of those symptoms. Sometimes we can use medications for generally that might be used for bipolar disorder, for example. The antipsychotics may work well if there are other associated problems. We generally do not recommend using a benzodiazepine such as Ativan or Klonopin because these medications can have a rebound effect and indeed can disinhibit people so that you end up creating many more problems rather than solving them. I mentioned the term apathy before. Apathy is a combination of symptoms where basically people have lost a lot of interest in doing things. Emotionally, it presents as an emotional blunting, reduced emotional displays, a loss of empathy. And just when you talk to people who are apathetic, they appear indifferent. Behaviorally, this presents as social withdrawal. There can be a lot of, just a loss of self-initiated behavior and very little spontaneous conversation. People would require a lot of external stimuli or prompting to perform pretty much any physical activity. And once they start those activities, they'll likely peter off and stop. There's very poor persistence. Cognitively, there's a lack of interest in routine or novel activities that people routinely used to like. And there's a difficulty in planning and implementing actions to achieve a goal. And there's a lot of reduced curiosity that people might otherwise have had. All of these things can represent a pattern of apathy. And apathy can commonly occur, unfortunately, in Huntington's disease. I mentioned depression as well. Apathy has an overlap with depression. In apathy, you might see a decrease in motivation, initiation of activities, and real indifference overall. The overlap with depression will occur particularly with a decrease in energy, interest, insight. People physically would tend not to move very much. In addition to the typical symptoms we think about in depression, a sad mood, a sense of hopelessness, a sense of guilt or self-criticism, all of those kinds of things, a reduced appetite, changes in sleep, and so forth. So all of those things can be a part either of depression, of apathy, or the overlap. And both of those, depression and apathy, can present in the context of Huntington's disease. So to treat apathy, some of the things that we can do behaviorally would be to provide daily structure, make it consistent, predictable, and provide encouragement to engage in social or physical activities. And then here's the balancing act, not nagging, but just encouraging. Pharmacologically, many times medications can be prescribed in doses that may be too high or are prescribed for other illnesses, whether it might be for hypertension, high blood pressure, or other disorders. They may be causing apathy. Or they may contribute to it. So it's important to discuss this with your prescribing physician to see what might be reduced if someone is dealing with apathy. And obviously, if they have other symptoms that suggest depression, to actively treat the depression as well. And so an antidepressant may be recommended. And even if it's unclear if a depression is present, but it's very clear that apathy is present, an antidepressant, particularly some that might be more activating, might be very useful. It's important to recognize, though, in the treatment of apathy, if someone is given an energizing or activating medication, It may lead to more anxiety or irritability. So it's just important to recognize that. So we're going to be thoughtful in making sure that we're working to help people and not inadvertently causing problems. Now, I talked in general about mood changes before as well, and that can include people being more irritable or more likely to respond in an aggressive manner when historically they might never have done so. This is a consequence of Huntington's disease, where the brain itself, technically the prefrontal cortex, is suffering and there is disinhibition. What we normally have as we grow is an ability to inhibit behaviors that might otherwise be inappropriate. As Huntington's develops for many individuals, they may lose the ability to inhibit those inappropriate responses or behaviors, and they may not even be aware of it. So it's important to recognize that this can be a part of the illness, and individuals may not even recognize it. And so as we look at this, what we try to do is to think through what are the specific issues. Occasionally it can be explosive reactions to very mild provocation, or to just say no to someone when they might want to do something. And it may be physical or it might be verbal. And it's obviously so uncomfortable for the whole family. And it is very difficult to cope with because it's hard not to take it personally. But the big challenge is for all of us to recognize it's the illness and not the individual. So part of the challenge when people are suffering with this and there are these, the lack of inhibition, part of that is expressed as, people not having certain emotions that are normally a part of the array of things that help us to keep inappropriate behaviors in check. People may not feel embarrassed. They may not feel afraid. They may not feel shame. And so when those feelings are no longer really present, you can understand why it may be more common for people to have these problematic and difficult behaviors. It can even occur if you're taking someone shopping, because they may see something they want and they may just pick it up and take it. And so there have been situations where people have actually been arrested for shoplifting. And the caregiver who might be with them might not have even recognized that it happened until it's too late. So what are the causes? Well, certainly, when people are in pain or there are other psychiatric illnesses that are existing, it's important to recognize that those can also trigger. I think many of us can recognize when we've suffered even a minor illness, relatively minor compared to Huntington's disease, a bad cold or a flu. Many of us are lousy patients and we get irritable and we can be very agitated and grumpy at the very least. So it's important to recognize that lots of illnesses can lead to this, but it might not be the Huntington disease itself. It could, as I've mentioned, be medication side effects. And if people are using alcohol or other drugs, that may be disinhibiting. We know that those can be disinhibiting. If people are having problems not sleeping enough, insomnia over days and weeks can make it difficult to inhibit inappropriate behavior. And keep in mind, as the disease progresses, and it may be difficult for people to recognize or express their needs as clearly as they might otherwise, they may be hungry. They may be too cold or too hot. They may be afraid and experiencing fear, but may not be able to articulate it. And so it comes out as irritability or aggression. In terms of medication, for severe or sudden agitation, we can use an array of different medications such as antipsychotics or anticonvulsants that can really help people gain more control. And these can be very, very important and very valuable tools to help people function at a much better level and to make the whole family more at ease and able to provide engaged care. Medications can also be used and monitored for people who are more in end stage, and particularly for those who are unable to verbally communicate when they might be in pain or distress and may frequently be agitated. So that it's important as we work with people to remember and think about the stage of the illness as we're providing care. Anxiety. Almost everyone at some point is anxious, but certainly those who are dealing with Huntington's disease can experience anxiety. The person can also have very persistent or obsessional thoughts, thoughts that occur over and over again, and they get stuck on them. I want this, I want this, I want this. Or they can have these compulsions, whether it's hand washing, picking at themselves, checking to make sure something is closed or opened. And they can lead to panic attacks. And individuals can feel like they're having a heart attack. And so these can be very, very serious and debilitating aspects. And so we can help to treat them. Now, normally, we would treat anxiety initially with psychotherapy and help give people the tools they need to help to manage their anxiety. And psychotherapy, skills-based cognitive therapies can be very, very valuable. But as Huntington's disease progresses, people may not be able to use psychotherapeutic tools in the moment. It may not be capable for them to. So medication can help enormously. Certain classes of antidepressants, like the selective selective serotonergic agents like SSRIs, can be very beneficial for helping to reduce anxiety. And if one initial antidepressant isn't beneficial, then alternatives may indeed be. And it's also possible if the anxiety is severe and if there is a problem with chorea or the movements that may not be adequately treated, antipsychotics can also help to treat significant levels of anxiety. We've also talked about depression, and clearly depression is the single strongest factor that may lead to people feeling that they're hopeless, they're helpless, or they may indeed even feel suicidal. And in depression, symptoms can vary from mild to severe. It certainly includes feeling sad or blue, losing interest in activities. It can affect our bodies physically as well as our emotions and cognition, our thinking. So our appetite can change. We can eat more or eat less. And we have sleep problems that can be part of depression. We can feel worthless. We can feel guilty. We can have problems thinking and concentrating, and we can absolutely have thoughts about death, dying, and of suicide. So it's really important to recognize this, and above all else, to recognize for many, many years, many people were afraid that if they asked someone the question, are you thinking of hurting yourself? We might be giving them the idea that they might then go and act on it. Years of research, years of clinical care have taught us that's simply not true. When we express concern and ask those questions, it reduces the barrier for people to share any existing feelings they may have, any fears they may have. It's an enormous lifting of a burden. Oh, thank you for asking. I was so scared of letting you know that because I didn't want to add an additional burden to you, is all too often what is heard. So please, please do not hesitate to openly ask the question, if you're worried, are you thinking of hurting yourself? Medications for the treatment of depression, we've gotten really good at helping to treat people with depression. And the number one choice for treatment are the antidepressants such as the SSRIs. There are lots of alternative antidepressants if the first choice is ineffective or if there are side effects that are uncomfortable for the individual. An SSRI is a medication that selectively focuses on serotonin, and serotonin is one of the brain messengers, neurotransmitters that carry signals to brain cells. It's one of the most common neurotransmitters in the brain. And these antidepressants block serotonin from being reabsorbed, making more of it available and increasing the amount of serotonin to allow the regulation of the disturbance that leads to depression. So we've talked a lot about the different medications, some of the specifics, but something to consider is, why is it so hard to change the behavior of someone who has Huntington's disease? And I think any of us who have served as either caregivers or clinicians working with people with Huntington's has addressed this concern. And the answer is a really long word, a word that's too long to even be useful in Scrabble. It's anosognosia. And anosognosia is an invisible symptom. What it means is a lack of knowing yourself, a lack of self-awareness. It can be caused by brain function changes that monitor how we act and behave. It was originally recognized in certain victims of stroke, where they could look in a mirror and not see half of their face. They literally would shave just half of their face and ignore the other half. That's a profound and obvious example of anosognosia. But you could think of it in the same way that alcohol, when we are drunk, makes our brain not function well. Ask someone who is drunk if they're okay to drive, and they'll say, sure, give me the keys. They have no insight into their own impairment. And that is very much the case for many people dealing with Huntington's disease. So they may all too commonly fail to recognize their own movements. Others may be very uncomfortable watching the chorea or all of the movements associated with Huntington's disease, but the individual may not even be aware that they're happening. And they may also fail to recognize that a lot of these behaviors are even inappropriate. Remember, we were talking about disinhibition, the inability to recognize anymore because of the absence of some of those emotions of shame or embarrassment that we normally have, because those parts of the brain are damaged. And many people will also fail to recognize their thinking has been altered. So the person with Huntington's usually isn't acting out or being aggressive or irritable on purpose. They may not even recognize that they're doing it. So what can you do as caregivers and family members? Well, the first thing is planning. Try to think in advance, try to avoid stressful situations wherever it's possible. Try not to get upset or to yell at the person with Huntington's disease because of their behaviors, because frankly, it won't work. Staying calm and using a gentle voice will. Using reason isn't going to work, even in someone who had been very high functioning and was always logical, may not have that capability at this stage in the disease. So arguing with them and trying to reason with them simply may not work. Also, try to avoid physical contact if you can. If you have to, try to leave the room or the house if need be, just to reduce the risk of conflict. Allow the situation to decompress and to calm down. So being proactive as a caregiver is critical. Using resources such as those available here at HD Reach and in the rest of the HD community is really, really important. Talk to your friends, teach them about Huntington's disease. Again, keep things routine and predictable. If things are predictable, people are far less likely to become irritable that they weren't expecting it. It's also important to please rely on your HD caregiver team. Build a relationship with us and contact the team when you need to. But here's a hint. Tell the person in your family with HD that you are contacting the team. Please don't hide it. And please, please, please don't call and say, please don't tell him or her that I called you. That puts us as caregivers in this horrible bind. And it really makes it hard for everyone to trust each other. And if we're going to make it through this, we need trust. We really do. So a few of the don'ts are trying to avoid certain things. Whenever possible, try not to be too rigid or controlling. And given what you understand of the individual you're caring for, try not to be overly demanding. If you can structure things and giving people space and time, you'll be able to find that the day will go much better. Try wherever possible not to be critical, because your goal, if you're being critical, is to get people to change their behavior, right? You did that badly. Here, let me show you how to do it the right way. That may not work anymore. And so try wherever you can to treat yourself with kindness. Try not to get angry when the person with Huntington's disease forgets things, when otherwise you might be very upset and irritable. And please don't allow yourself to be verbally or physically aggressive. You can manage your loved one in this condition if you take care of yourself as well. Something that helps, and we've been talking about this, is being consistent, having structured schedules. And it's also important in this context, remember, when it comes to irritability and complaining, if someone with Huntington's disease knows you're eventually going to give in, you're teaching them to be irritable and aggressive to get what they want. So at that level, that learning, remember when we were raising children, for those of you who have young children, it's the same sort of thing. If children know that will eventually give in, they'll keep nagging until they get what they want. So it's important. Be consistent in the care you deliver. And if you're going to say no to something, be consistent with that, or you're setting yourself up for more frustration. It's also important to have family rules. Let the person with HD know the rules ahead of time. And when I'm talking rules, I'm talking sometimes serious issues. Occasionally, people with Huntington's disease may end up becoming more and more agitated and aggressive. You need to be really clear among the family if you'll need to call the police for your own protection and theirs. And it's really helpful to do this when you're in a clinical session with a healthcare professional, so that everyone in the care team, you as the caregiver, the patient with Huntington's disease, and the caregiving team all know what to expect. So if you as the caregiver are going to say, and you structure this rule, if you threaten to hurt me, if you grab a knife, if you start to punch me, I am going to walk out and call the police. That's the only way we can be all safe. That might be one thing that some families may need to do. And if that is a concern, work to do it up front when it begins to be an issue, not later on. Everyone's safety is critical. As caregivers, you need to be safe. If you're threatened, if you feel scared or abused, get away from the situation, call the police. Once things are calmer, and then you can engage not just the police, but emergency responders and the Huntington's caregiving team. Then you can work out the next steps in the overall plan. So I've tried to emphasize that in this process, you as a caregiver need to take care of yourself. Because unless you are taking care of yourself, you can't take care of anyone else. Being a 24-hour-a-day caregiver is exhausting. It can lead to stress, your own depression, your own anxiety. It's a hard job. And it can get really very, very difficult when the patient with Huntington's has still uncontrolled symptoms that are not yet controlled either behaviorally or with medication. They can be very self-centered or abusive because of the illness of Huntington's disease. And it can be difficult. Look, for all of us, it's difficult as a caregiver when you don't feel appreciated and you don't hear from your loved one with Huntington's the words, "I love you" or "thank you." It's also important to recognize it's okay for you to want to have a life. We need to come up with strategies so that you can come up with time for that, things that are important for you. It's important to remember that, even if you are a parent of someone who has Huntington's disease, it's important to recognize that if one of your children may be at risk for Huntington's, the intention is never to give the disease to someone, to one of your kids. So sometimes we carry a lot of guilt and a lot of fear and a lot of anxiety even about that. So it's important, on that topic to really take time to discuss any issues around those concerns with the whole Huntington's team, because we have trained for a long time to provide that kind of support and care for you. As a caregiver, you need to find a place to recharge and to recover your energy. You need a good support system. And that can be through your religious organizations, social groups, your extended family. It can include a therapist or the HD team. There are caregiver support groups, whether online or in person, depending upon where you live and the environment. So we can help you connect with those resources, but it's so important to recognize it's not all on you. There are many people who want to support and help you. How do you do it? Well, some of us have grown up as caregivers for so long, we forget how to take care of ourselves. But some of the simple things, for some of us, it's taking a break in a quiet room, listening to music, meditating, simply reading a book that you enjoy, going for a walk, absolutely making sure you find a way to get enough sleep. Because if you're sleep deprived, you're going to get cranky, irritable, and you're setting yourself up for so many other problems. It's important for you to eat a healthy diet and drink plenty of water. Stay physically as healthy as you can, and have regular health checkups. So, some final thoughts. Remember that symptoms of Huntington's disease, including all of those mood changes, are the illness. It's not the person. It sometimes has to be a mantra that we repeat because it's hard to separate out those symptoms and those behaviors from the person you love. But it's not that person that you love that's behaving that way. It's the illness driving this. It's so important to find a team of healthcare professionals, build that relationship, and work closely with them. Have open communication. If we talk with each other, we share, if we ask for help when we need it, you'll find that it's so much easier to build a supportive network that will allow all of you, the person with Huntington's disease and you and your family, to thrive and get through this entire process. So unless there are, when you start taking a medication, it's important to recognize that most of these medications don't work immediately. What can happen immediately are some side effects that you should have been just, described when the patient was prescribed the medication. So it's important to recognize, even though there may be some mild side effects, stay on the medication. And when I say stay on it, work collaboratively with your caregiver team, but most medications are going to take a month or more before you start to see really beneficial effects. So unless there are unbearable or critical side effects, please stay on the medication, or at least before stopping it, talk to the caregiving team, talk to the HD team. Again, find a team of healthcare professionals, work closely with them. Open communication. You heard the theme, right? Communicating, talking, gaining strength from building this network is what is going to help you. So all of us are impacted by Huntington disease. It's you, your family, as well as the individual with the disease themselves. Everyone in the family is equally important. And please remember, if you take care of yourself, you can better take care of the person with Huntington's disease. So, you can certainly reach out to everyone in the HD Reach community. And really, please, I can just encourage you to be very open and ask. If you don't know something, there are others who will, and so many of us who want to provide help and care. So with that, let me stop talking and see if there are any questions that I might be able to address. I haven't been able to see the chat, so let me turn it back over to Debbie and Erica, please.
Hi, Bob. This is Debbie. I don't know if you can see me right now. I don't see myself on the screen, but we did have a couple questions come in. And if you have a couple minutes, I'd love to ask. These are some really good questions. The first one was, how do I help someone who tries to put themselves in a dangerous situation, but is not open to seeking support?
This is an ongoing issue, and it depends on what the dangerous situation is. One of the biggest challenges that most of us have faced in providing care is, for example, driving. And many, many people with Huntington's disease refuse to believe that their driving is impaired. And so what we end up needing to do is working with the family if there are issues. Many centers who provide care for Huntington's may be able to do an off-road exam to give some sense of whether it's safe to drive. And if there are any concerns, to refer someone to the Department of Motor Vehicles for them to have another driver's test. So that is one of the bigger challenges and opportunities. If the state withdraws their license, then the family would be obligated to keep the keys away from them. If it is taking a walk at night without anyone around, with the risk of being lost, these are challenges, and it requires sitting down and working with a team to come up with strategies, because they're so different based on the community in which you live, as well as the environment in which you are, what resources you have. But at some point, depending upon the level of risk, it may be important to look at alternatives to keeping that individual at home in the extreme cases.
Okay, thank you. And somebody else asked, if somebody confides in me about thinking about harming themselves, but has not done anything yet, how do I help them without getting them upset with me?
This is the communication issue. And the real issue is you may upset them, but if you don't respond, you may be living with what happens as a consequence for the rest of your life as well. So it is so important to talk up front initially. That's why planning can make it even easier. So you can, with the caregiver team, and I'm talking first about the ideal situation. The ideal situation will be that you as a caregiver with the patient and the clinicians talk about it in advance. The clinician will typically, as part of the interview, ask, have you had thoughts about hurting yourself or taking your own life? That sets the stage. And then you in that meeting can ask, is it okay for me in between times for me to ask someone, ask my loved one if they're thinking of hurting themselves, and set up that dynamic. That's the ideal. If it's less than ideal, it would be appropriate for you to say, you haven't talked much. You've really been withdrawn. Is there anything I can do? No, I'm fine. Are you thinking of hurting yourself? Why are you asking me that? Because I care for you. Just be upfront and be very direct. And sometimes it's very important to recognize that sometimes we need to do things that can upset people. But if they do get upset, again, those ground rules. If they get upset, say, I see you're upset. Let me take a step back. I'll come back in 5 minutes, and we can do a puzzle together. We can watch TV together. And most people in 5 minutes will be off and thinking of something else and will no longer be focused on that concern anymore.
Great, thank you. And lastly, I've got one other question. If I know who my friend's neurologist or psychiatrist is, and I know my friend is having thoughts of harming themselves, would I be able to call their care team to let them know, even if they don't know who I am?
So there are all sorts of laws about protected health information, but that information is based on the relationship between the patient and the caregiver, the doctor, the nurse, the social worker. And so if someone else, another family member for whom there is no release of information, a family friend for whom there's no release of information, wants to talk to the doctor or to the care team and give information, that's fine. You see, you're not breaking the patient-doctor, the patient-clinician relationship. You are contributing information to the care team, and then the care team can take that information, and it's their responsibility to then follow up with that. So I encourage you, if you see something like that, say something. Absolutely.
Perfect. Well, thank you. On that note, that does wrap up our questions. This has been an incredibly powerful presentation. This is a really important topic with this community. And I thank you, Dr. Trustman, so much for sharing your time and your wisdom with everyone here. And I want to remind everybody that's watching now or potentially watching in the future that this webinar is being recorded. It'll take about a week for us to get it edited, and then it'll be up on the website, and you can watch it again, or you can share it with anybody else that that this is such good information that's so helpful to help families plan, prepare, to cope with everything going on with their HD lives and to live their best lives. So I really want to thank you for being here. And I also just want to remind everybody that we do have more webinars coming up in our 2022 education series. The next one will be how to build your support network and your care team, which Dr. Trustman talked about the importance of this so much during his talk. So I really hope everyone can sign up. That webinar will be on October 18th. And then after that in November, we're going to have another webinar about how to talk to family members about getting treatment. So this is, again, something very topical, something that people are asking about, and we welcome you to come to that webinar on November 15th. You can register for them now on our website at hdreach.org. And also just remember that everyone here at HD Reach is here for you when you need us. And I just want to thank you and ask everyone to please take care of yourselves and have a good night.